Okay.
മിലിയോണെ ഇപ്പൊ വിളിച്ചിരുന്നു. ഇല്ല, അക്ഷയ അഞ്ജലിന്റെ ആണ് കുറച്ച് കഴിഞ്ഞിട്ടാണ് ഇട്ടത് അവരുടെ പേര്. ഞാൻ നേരത്തെ ഇട്ടാ മതിയായിരുന്നു. അപ്പൊ അവരുടെ കൂടെ എന്തായാലും ഒരാളെ കയറ്റേണ്ടി വരുമെന്ന്. ഒരു താമസിച്ചല്ലേ. അപ്പം
Good evening, friends. Am I audible to you?
Yes, sir.
Yeah. So let us start with today's session. And now it is too late. So without any introductory remarks, I will start this session. So today's topic is mainly on the management aspects of COVID. I think it is very important for all of you because nowadays you are posted in COVID side also. So it is a entirely different scenario for you, especially you are not at all familiar with this COVID patients in the previous during your the student days also. And also it is a new branch of medicine, we can say, because the patients are new and the drugs that we use are new. And there are different clinical aspects also which are entirely new to you. So I think today's topic is very important for you, especially when you are posted in the COVID side. So on 31 December 2019, we remember WHO was formally notified about a cluster of cases of pneumonia in Wuhan city. A brief mention regarding the history of COVID. By 5th January 2021, 59 cases were known and none had been fatal. 10 days later, WHO was aware of 282 confirmed cases, of which 4 were in Japan, South Korea, and Thailand. This was a brief mention about the history of COVID. And as you know, the COVID today, as of May 2021, there are a lot of new cases of COVID worldwide, which were being confirmed daily, and the death rate also was over 4,000 per day. And today's statistics from this Kerala is also, you know, the total positivity rate is also the maximum in India. I will just stop share and I will move to another PowerPoint presentation, which is okay. Now coming to the briefly regarding the structure of this this RNA virus, you know the details, especially it has got a nucleocapsid protein and RNA, and it has got a spike protein also that is very important regarding the pathogenesis of this COVID virus. These are the virology details. It is an RNA virus, and this RNA is surrounded by the nucleocapsid, which has got a helical symmetry also. It is the largest RNA virus among the all retrovirus families. This brief mention regarding the history, the virological part. Now coming to the mode of transmission, this COVID-19 is spread in 3 main ways actually. Breathing in air when close to an infected person who is exhaling small droplets and particles that contain the virus. That is the most important modality of transmission, that is airway transmission. Having these small droplets and particles that contain the virus, which land on the eyes, nose, or mouth, especially through splashes and sprays like a cough or sneeze. Then touching the eyes, nose, or mouth with hands which have been contaminated by the virus is an important modality of transmission. Now, there is a debate regarding this aerosol transmission, whether it is occurring or not. The one thing is sure, it is mainly transmitted via these droplets, especially when the person is in close contact with an infected person. Airborne transmission is also another doubtful condition, but this droplet transmission, where the patient coughs and sneezes, where millions of droplets of the virus particles are released, that is an important modality of transmission. Now coming to the most important aspect of today's session, that is treatment guidelines. That is, there are different guidelines for the management of COVID. We will discuss briefly the Kerala state version, and it is also based on the ICMR guideline as well as the guideline that is published by the Ministry of Health and Family Welfare. There are mainly 4 pillars in the management of COVID. That is, one thing is this Remdesivir, that is the antiviral drug. You might have come across the patients who are receiving this Remdesivir. Then steroids are very important in the management of COVID. It has got a very important anti-inflammatory role and reduces the mortality also. And anticoagulants also has got a very, very important role. And finally, this oxygen. Oxygen is also considered as a drug in the management of COVID. Before mentioning regarding these drugs, I will briefly go through these categories which were already discussed in the previous classes. These are category A, category B, and category C. This category A, as it is shown here, it is patients with very mild symptoms, cough, rhinitis, diarrhea, etc. And they may also have this anosmia, etc. Whereas category B includes all these patients with category A with any of the comorbidities. For example, if they are having any CLD or COPD or uncontrolled diabetes, all such patients will come under the category B. And patients on long-term steroids or rheumatoid arthritis or any other conditions also come under category B. One important thing I have to highlight is all pregnant patients, pregnant ladies will come under the category B. And also persons who are more than 60 years also come under the category B. So these category A and category B are usually not coming to our hospital. All the patients that is coming to our side, which is a tertiary care center, is category C. So the patients with the breathlessness, maybe because of pulmonary embolism or maybe ARDS or whatever it may be. Patients with the chest pain, maybe because of the myocardial infarction. Patient with the drowsiness, maybe because of the metabolic encephalopathy, fall in the blood pressure, then hemoptysis, cyanosis. All these are considered as the red flag signs. So all these patients who are terminally ill and who are having complications will belong to the category C. And this category C patients will come to our hospital. Category A and category B are treated either in the home or maybe treated in the managed in the this COVID first line or second line treatment center. So this categorization, the purpose of categorization is mainly to decide to which area the patient has to be sent for management. Category A can be managed either in the home or can be managed in the COVID first line treatment center. And category B has to be managed in the second line treatment center. For example, in Alleppey, this general hospital or our WNC hospital, all these are second line treatment centers. Whereas category Z will manage it in the medical college hospital, our hospital, which is the tertiary care center. So we have to concentrate mainly on these category C patients. Then again, another classification of patients into mild, moderate, and severe is also important. This is mainly based on 2 criteria: their respiratory rate as well as their oxygen concentration. The respiratory rate of the patient per minute is less than 24, and the SpO2 concentration is more than 94. They are categorized as the or classified as the mild patients. And if the respiratory rate is more than 24 but less than 30, and they have breathlessness, and if the SpO2 concentration that is measured by the pulse oximetry is more than 91 but less than 94, then such patients are also included in the this moderate category. The severe means the respiratory rate is more than 30 per minute and the SpO2 concentration is less than 90. So this classification is very important. Mild means less than 24 respiratory rate, SpO2 is more than 94. Moderate is more than 24 but less than 30 respiratory rate. SpO2 is between 91 to 94. Severe means respiratory rate is more than 30 and SpO2 is less than 90. So this category, this classification is also very important considering the management. So mild patients, they need only home care. They can be managed in the home with the physical distancing, then indoor mask use, then strict hand hygiene. Then the symptomatic management also may be advised for them: hydration, antipyretics, for example, paracetamol may be given, antitussives or multivitamins if necessary. Then they have to be in contact with a treating physician, and they have to monitor their temperature and also oxygen saturation by using this pulse oximeter, because this is very important factor by which we will classify the patients into mild, moderate, and severe, as already it was mentioned. So while the patient is in the majority of the patients can be managed in the home because of the mild symptoms which they have. Then there are high risk for severe disease or mortality. Those patients who are more than 60, they have cardiovascular disease or hypertension, they have diabetes, or those who have diabetes or other immunosuppressed state. All such patients will belong to the high risk for a severe disease, or they can at any time they can develop a severe disease. Also, patients with chronic lung, kidney, and liver disease, or patients with cerebral vascular disease, all such groups will at any time can degenerate into either moderate or severe disease. Obesity is also another important factor which can produce deterioration of the patient. You might have seen many patients in the COVID ICU as well as in the COVID wards who are obese with a body mass index of more than 30, having respiratory distress and many other complications. So obesity is a very important factor which can produce degeneration into moderate or severe category. Then if they are in the home and if they have got any of these complications like difficulty in breathing, or if they have got a high grade fever, or patient have got a severe cough, particularly if it is lasting for more than 5 days, in such cases we have to seek medical attention if they are when they are in the home. And now there are certain experimental therapies also, which are based on low certainty of evidence. All these are for patients who are in the home, who are having only a mild symptoms. Tab ivermectin is one experimental therapy. Hydroxychloroquine is also another drug that is used in the rheumatological conditions. And then inhalation of the steroids, especially budesonide, is found to be effective when the patient is in the home and who is having cough or other chronic respiratory symptoms. They can have this inhalation budesonide also. Now, coming to the moderate category, so moderate category, we have to admit the patient in the ward, and usually they are managed either in the COVID second line treatment center. There are severe patients we have to admit in the ICU, and such patients are in our center also. They are admitted in the ICU, and we are managing the severe patients, that is, who are having a oxygen saturation of less than 90 and a respiratory rate of more than 30 are severe patients. They have to be managed in the ICU. So this is in summary, this is the management schedule that we adopt. Asymptomatic patients we are treating as in the home. They are home managed patients. And then asymptomatic patients with no provision for home care. Such patients can be managed in the domiciliary care center known as the DCC. And category A patients having only mild symptoms have to be managed at the first line treatment center, already mentioned. Category B had to be managed at the second line treatment center. And finally, these category C patients have to be managed in a tertiary care center as in our hospital. And the patient needs some workup also at presentation when they are coming to the triage or when they are coming to the ward. We need a proper history of the patients. Vitals have to be examined, and physical examination also is to be done as possible, because COVID patients have a lot of limitations, we know. But we are in the PPE kit, etc. So possible physical examination also have to be done. Which are the clinical predictors of severity? If the person is an elder person, age more than 60, underlying non-communicable diseases like diabetes, hypertension, or chronic lung disease, chronic obstructive pulmonary diseases, etc. Person who is obese, already mentioned, and persons who are having the habit of smoking, smokers. All such patients can deteriorate at any time. So these are the clinical predictors of severity. So these are some investigations which you have to do. Complete hemogram is important. LFT, RFT also, because many drugs can change this LFT, RFT. ECG to assess the cardiac status. Inflammatory markers are very important. So these are the new investigations that we will do in patients with COVID, especially the C-reactive protein. Then serum ferritin is a very important inflammatory marker. D-dimer is a matter of it's a factor for coagulation. So this COVID is a hypercoagulable state. So D-dimer also has to be evaluated. IL-6 again another inflammatory marker. So these are the inflammatory markers. Except this IL-6, everything is done in our side also. So this is also very important. Then radiology, X-ray, chest, PA has to be done in all patients, and also CT when indicated. We will see which are the indications for CT. When there is a clinical suspicion of COVID, but the RT-PCR is negative, so such conditions can occur. Patient is having a high suspicion of COVID because he or she had a primary contact with a high-risk contact with a patient, but the RT-PCR is negative. In such cases, we can do a CT thorax. Then we are suspecting alternate diagnosis like TB. Then also we can do a CT thorax. Then complications are there like pulmonary embolism. Then evaluation for the post-COVID fibrosis. These are the 4 indications for CT thorax in patients with COVID. Which are the poor prognostic markers? Patient having a lymphopenia, then patient having elevated liver enzymes, CRP, IL-6, etc. Elevated troponin, and the inflammatory markers and acute kidney injury. All these are the poor prognostic markers in COVID. Now, coming to the drugs that are used in the management of COVID, there are 3 A's. One is the anticoagulants, then anti-inflammatory drugs are there, then the antiviral drugs are there. These are the 3 A's. And oxygen is also considered as a drug in the management of in COVID. Remdesivir is mainly used in the early phase of the disease. It is an antiviral agent. The patients who are within 10 days of onset of symptoms, then only we have to use this Remdesivir. This is very important. And those requiring only low flow oxygen. The patients who are requiring only a low flow oxygen, and patients who are within the viremic phase of the disease, that is the first 10 days of the disease, we have to give Remdesivir. The dosage is 200 milligram. It is a parentally used drug. 200 milligram IV on the first day, followed by 100 milligram daily for next 4 days. Only 4 to 5 days treatment is given. Not to be used. This is very important. Remdesivir should not be used in patients who are not on oxygen support or in home settings. So we have seen many cases of patients who are coming from the home, who might have received this Remdesivir while they were in the home, but that should not be done. It is a drug which has to be used in the viremic phase, that is within the first 10 days of the illness, and that too when they are requiring oxygen support, and mainly when they are in the wards or in the ICU. Then only we have to use Remdesivir. These are the contraindications. When the AST-ALT elevation is more than 5 times the upper limit of normal. For example, if the SGOT-HPT is in the range of 200 or 250, we should not use. Then when there is a renal insufficiency and there is a need for hemodialysis, we should not use. Pregnancy and lactation, and also in children less than 12 years. In pregnancy and lactation, when in certain selective cases, with the consent of the patient or the relatives, in selected cases, while considering the risk and benefit, we may use this Remdesivir in certain selected cases of pregnancy and COVID. Another oral drug that is antiviral drug that is used is FAVIPIRAVIR. The dosage is 1,800 milligram first day, twice daily, followed by 800 milligram daily. The side effects include teratogenicity, then transaminitis, then neutropenia, and dose-dependent hyperuricemia. All these are some of the side effects of this FAVIPIRAVIR. Now, coming to the anti-inflammatory, or the next modality of treatment is the anti-inflammatory or the immunomodulatory therapy. Most important one is the steroids, that is using either methylprednisolone or an equivalent dose of dexamethasone. Dexamethasone usually we give in the dosage of IV dexamethasone 6 milligram OD. Remember, this is one viral infection where we are using this the steroids as a modality of treatment. 1 minute. ഞാൻ ഔസൻസിന്റെ ക്ലാസ്സിലാണ് ഞാൻ വിളിക്കാം ശരി. So this dexamethasone we will give in a dose of 6 milligram OD as per the recovery trial, which is the trial which have shown the benefit of dexamethasone. it has got no proven role of increasing the dosage, because steroid while using COVID, you have to be careful also, because many of these patients are having diabetes also. So steroid we cannot use in a high dosage. So remember, steroid, the dexamethasone, the dosage of dexamethasone in COVID patients is IV dexamethasone 6 milligram OD. And or we can use methylprednisolone also, especially in pregnancy. We used to give methylprednisolone because it does not cause a placenta. So in pregnancy patients, we are using methylprednisolone. Now, the third modality of treatment after the antiviral, that is Remdesivir or FAVIPIRAVIR. Second, the anti-inflammatory, that is steroid. The third modality of treatment is anticoagulation. Again, here we have to remember an important point. This is mainly given in a prophylactic dosage, not in a therapeutic dosage. Conventional dose of prophylactic unfractionated heparin or low molecular weight heparin is given. That is about 0.5 milligram per kilogram per day is the dosage, and it is not a therapeutic dosage. There should be no contraindication or high risk of bleeding while we are giving this anticoagulation. Patients hospitalized are preferably anticoagulated with a prophylactic dosage, usually 0.6 ml OD is the dosage of low molecular weight heparin. And when it is a therapeutic dosage, that is therapeutic anticoagulation is done only in confirmed cases of thromboembolism. For example, if the patient is having a DVT or the patient is having a proven case of pulmonary embolism, then we will give 0.6 ml BD. Otherwise, once daily is sufficient for, or a prophylactic dosage is sufficient for patients with COVID anticoagulation. Now, there are certain experimental therapies. So, three drugs we already mentioned is antiviral, anti-inflammatory, and anticoagulators. Now comes this another important drug, that is the Tocilizumab, that is a IL-6 inhibitor, and it is especially used in patients with a significantly raised inflammatory markers. And we should ensure that there is no active bacterial, fungal, or tubercular infection before giving this Tocilizumab. The recommended dosage is 400 milligram initially, and it has to be given diluted in normal saline. This drug is also available in our site. This we will give only when the patient is not responding to this conventional treatment, and the patient within 24 to 48 hours, patient is deteriorating immediately. Then category C patients who are not responding to steroid and they are having high inflammatory markers. In such cases, we will give Tocilizumab, which is a costly drug. And these are the two important indications. In ICU, the patient admitted within the past 24 hours, patient requires invasive mechanical ventilation or non-invasive ventilation or high flow nasal oxygen. In such cases, we will give in ICU. If the patient is not in the ICU also, patient is recently hospitalized, when there is an increase in the oxygen demand or use of NIV or HFNC, we have to give Tocilizumab. So in summary, we can say Tocilizumab is given in patients who are in the critically ill stage, who are not responding to this conventional treatment, and who are showing high inflammatory markers in spite of the steroid as well as other modalities of treatment. In such cases, we will give Tocilizumab. Then coming to the last group of drug, this oxygen support, we can say oxygen is a drug in patients with COVID. The target SpO2 is 90 to 96%. We have to maintain target SpO2 at this level. And in patients with COPD, about 88 to 92% is sufficient. And awake proning is another important method of keeping the patient in the wards or in the ICU if possible. This will improve the oxygen supply, as well as the respiratory support will be improved in patients with this awake proning, that we have to advise in patients with COVID. The goals of oxygen therapy in the ward is to maintain the oxygen concentration of about 94%, in the ICU about 92%. And there are three methods of oxygen therapy. One is the conventional oxygen therapy, then there is a high flow nasal oxygenation, and non-invasive ventilation. We'll see what each heading is describing. The conventional oxygen therapy, there are two modalities. One is a high flow, where the system provides all the patients an inspired gas. That is one of the high flow oxygen supply. Whereas the low flow, the patient draws remainder from the surrounding air. And this is one important method of giving this low flow or this nasal oxygen. You may be familiar with this nasal cannula. The flow is low flow, that is 1 to 6 liters per minute, easy to use, disposable, low cost, and well tolerated. patient can eat or drink during this oxygen administration. Drying of the nasal mucosa is the main side effect with nasal cannula. There are different methods of giving this oxygen apart from the nasal cannula. Plastic masks are available. This is the high flow nasal oxygen therapy. Here, the heated and humidified oxygen is given as a high flow oxygen supplementation. The problem or the hazard with this HFNC is there may be a delay in the intubation. So, because we may believe that this is sufficient for the oxygen supply of these patients or oxygen need of the patient, but we should be vigilant while giving this HFNC also. We have to frequently monitor the oxygen saturation, and that if there is a significant fall, immediately we have to subject the patient for intubation. This is regarding this NIV, non-invasive ventilation. There are two methods. One is the CPAP, other one is the BiPAP also. We are using mainly the CPAP in our ICU as well as in the wards. It is a continuous positive pressure throughout the respiratory cycle. The CPAP is given. Whereas in BiPAP, there is varying level of positive pressure during inspiration and expiration. And there are contraindications for NAV, the uncooperative patient or hemodynamic instability, reduced conscious level, the copious secretions, persistent vomiting. These are the contraindications for NAV. Then at last we had to, there is no other way, we had to give this resort for mechanical ventilation when the patient is in severe respiratory distress. And fluid management is also important. The U volemia have to be maintained. This input should be equal to, as in any other medicine patients in our hospital, the output plus 500 ml should be the input. For example, if the patient is having a output of about 1 liter urine, then we have to give an fluid of about 1 liter plus 500 ml, that is 1.5 liter. Then the few mentioned regarding this JAK inhibitors, that is the recent development in the management of COVID. These are the JAK2 inhibitors. This includes the Tocilizumab as well as the baricitinib. These are also available in our hospital, especially this Tocilizumab. This is considered only for patients who have not received the Tocilizumab or on mechanical ventilation, who require this more than 8 liters of oxygen. In such cases, we can give this new molecules, that is the tofacitinib as well as the baricitinib. In rare circumstances, when corticosteroids cannot be used, again we can use this JAK2 inhibitors, that is the baricitinib or the tofacitinib. So those patients who haven't received this tocilizumab and who are cannot be used on steroids, such cases we can try these two oral drugs, that is the tofacitinib as well as the baricitinib. In our hospital, the main drug that is available is the tofacitinib. Dosage of tofacitinib is oral 10 milligram. It is given as twice a dosage, and the duration also we have to give for about 7 to 14 days. And regarding supplementation of vitamin C, vitamin D, vitamin zinc, etc., there are insufficient data, or they are not at all well accepted among the medical fraternity. But supplementation may be necessary in certain selected cases of patients. Now I will briefly discuss two cases. You can try to answer also. A 45-year-old man with no comorbidities became RT-PCR positive. SpO2 is 98. Such patients can be managed in the home, isn't it? Because he is in the category A. Such patient is ordered for HRCT test, and that patient was put on steroids and azithromycin, ibuprofen, as well as zinc. Is there any justification for this approach? 45-year-old man with no comorbidities. If there is no comorbidity, he is not in the category B, isn't it? He is in the category A. Became RT-PCR positive. SpO2 is also 98. So the patient belongs to mild category. So there is no need for any HRCT test. Already we have seen there are indications. There are 4 indications for HRCT. This is not an indication. Then patient was put on steroid. Again, there is no need of putting the patient on steroid if there is no need of any oxygen. Then azithromycin, COVID is a viral infection, no need of antibiotics. Ibuprofen, that can produce gastritis, so a simple paracetamol is sufficient. Then zinc, there is no data available regarding the supplementation with the zinc or vitamins in COVID patients. So simple in this patient, simple paracetamol and home isolation is sufficient for managing COVID while the patient is having these parameters. This is case 2. A 68-year-old lady, this rapid antigen test positive 14 days back, and SpO2 is 92. So this patient belongs to which group? The patient is belonging to this moderate category because the oxygen saturation is 92. It is between 90 and 94. So it is a moderate category. That patient is put on Remdesivir. So what is the fault in this putting the patient on Remdesivir? Anybody? The patient is positive since 14 days. So only when the patient is positive, within 10 days, we have to give Remdesivir, isn't it? Antiviral. Convalescent plasma. Nowadays, convalescent plasma is not at all there in the protocol. So that is also not used. And piperacillin. Piperacillin is a high antibiotic, a hair antibiotic. That is, there is no need of any hair antibiotic in patients with COVID. So this point we have to remember. In a patient with a positivity of 14 days, there is no role for antiviral agents. Then case 3, 28 weeks pregnant lady with COVID, SpO2 is 91. Again, category B, or a patient is on a moderately severe, illness is there. Injection Remdesivir. Again, Remdesivir is of doubtful value or in patients with pregnancy, and we had to consider many other factors before considering Remdesivir. Risk and benefit are to be considered. Injection Dexona. In pregnancy, it is better to give this methylprednisolone than Dexona because Dexona will cross the placental barrier. And injection heparin. Yes, injection heparin is indicated in a pregnant lady because pregnancy itself is a hypercoagulable state. So in such cases, we have to give heparin for a particular period of time when the patient is there in the hospital and the oxygen supply is low. So these are the few cases which I would like to highlight to stress the importance of managing the patients at different stages with different drugs. So to summarize, categorization is necessary for admission, staging for the treatment. Categorization for admission: category A, CFLTC; category B, CSLTC; category C in the tertiary care center. Staging for treatment: mild cases we can manage in the home, the moderate cases in the ward, and the severe cases we have to treat in the ICU. In the home care, there is no need of any investigation or medicines. Remdesivir should be given only within 10 days of illness. Steroids are given for 5 to 10 days. Anticoagulation has to be given in the prophylactic dosage. Plasma, nowadays we are not using plasma. Then supportive drugs have got only inconclusive evidence in the management of COVID. So that is all regarding the management of COVID patients. So a few points I would like to highlight again. This categorization as well as this severity staging is very important in all cases of COVID before we proceed to manage these patients. So this categorization is mainly for the decision regarding the hospital where we had to manage the patient, whereas this staging is mainly for the treatment modality which we had to give while the patient is in the hospital. That point also we have to remember. Then another important point is regarding the use of steroids. Steroid we should not use in a high dosage because high dosage of steroid can produce various other complications, including the diabetes will be uncontrolled. So steroids have to be used in the therapeutic dosage only. Anticoagulation again we have to use in a prophylactic dosage only. And while discharging also, because people are writing the discharge case sheets also. While discharging the patient, we had to ensure that the patient is getting this tapered dosage of steroids. That is very important. And also we had to put the patient on newer oral anticoagulants. That is also very important. The newer oral anticoagulants like apixaban we are using for a very long time, maybe for 7 to 14 days, because the patient can develop post-COVID sequelae in the form of thrombosis and embolism. So in every discharge card, the patient needs steroid in a tapering dosage as well as anticoagulation in for a period of 7 to 14 days. So that is all regarding the update on the management of COVID. I know there may be many doubts from your side, which we can discuss if necessary. If you have some doubts, we can discuss now, or we can discuss later also. And the further classes, we will discuss various management of various complications of this COVID, including COVID and heart, COVID and lung, and then COVID and diabetes. Such complications or such comorbidities, management of COVID in comorbidities, we will discuss in the subsequent classes. If you have got any doubts, you can ask me. If there is no more doubts, okay, I think we will stop here. And tomorrow also there will be classes, and it is a series of classes. And if there is any practical doubts in between, at any time you can contact us and clear the doubts. Okay. Thank you. Good night.
Thank you, sir.
Good night.
Thank you, sir.